Great. Hello, everyone, and thank you for joining us this afternoon. My name is Jasmine, and I am the YES coordinator here at the North Suburban YMCA. It is my pleasure to welcome you to Healing Shoulder Pain Naturally by Denise Schwartz, licensed physical therapist and owner of the Manual Touch Physical Therapy in Wheeling. Today, she'll be walking us through a workshop that will help identify causes of shoulder pain and how to ease shoulder pain. We will be recording today's session to make it available as a podcast on our WISE website, so if you are a Y member, you will be able to reference it down the road as well. The YMCA Education Series programs typically last an hour. Denise will take questions at the end of her presentation. If everyone can mute themselves during the presentation so that the background noise doesn't interfere with the presentation, you can then unmute yourself when she opens the forum for questions. The YMCA Education Series programs is free and open to the public, but as a nonprofit organization, we are always happy to receive donations from you. If you enjoyed today's program and would like to support adult programming at the NSYMCA, please feel free to make a donation to our Y by going to our website at www.nsymca.org. Again, thank you for joining us today, and a special thank you to Denise. Now, I will let Denise kick off today's workshop. Please welcome Denise.
Thank you, Jasmine. And it's the beginning of the new year for me doing this. I haven't done a program in a few months, and it's the first time Jasmine and I met, so it was very lovely meeting her. I'm going to share my screen, and I'm not going to be able to see anyone, so if you have any questions, please put it in the chat box, and we'll get to them later. Oops, hold on. I got to go to the beginning here. Hold on. There we go. Okay. I'm also not able to see myself either. So if anybody has anything or urgent, just please put it in the chat box. Jasmine, you can see my mouse?
Yes, I can.
Okay, cool. All right, we are good to go. Again, thank you, Jasmine. My name is Denise Schwartz. I'm a physical therapist and owner of the Manual Touch Physical Therapy in Wheeling. We use traditional and non-traditional therapies to get people back doing the things that they love to do. And I've been a PT a really long time. So I wanted to start off with a little story. A few years ago, my son, here's my son, came to me and said, you know, Mom, can you help me with some injuries? I want to get back to triathlon racing. Now, Drew, who is now 28 and married, began triathlon racing when he was 14. And it wasn't long before he was winning his age group in every race he entered. And after college, a number of years ago, he took a couple years off. Oh, and he went ahead, you know, to become a junior elite racer later in high school and competed at the collegiate level, even getting nationally ranked. And then he took a couple years off of college to nurse some injuries and learn how to be an adult in the world. And so when he came to me a few years ago, I was really grateful and excited to help him get back to triathlon racing. So he was making his return to the Pleasant Prairie Sprint Triathlon in Wisconsin, Pleasant Prairie, Wisconsin, where he would swim a half a mile in a small lake, bike 12 miles, and then he would run a 5K. This is from a race he was in where a bunch of boys jump in at the same time. So when he first came to me, I videotaped him running on the treadmill, and I analyzed it, and I gave him some running tips, some running form tips. I gave him some exercises. I did some hands-on manual therapy to make sure things were working okay. And he was very good about doing all this, but what he really needed from me was to provide him with reassurance and encouragement whenever a little niggle would pop up. You know, more than one night I'd get a call, Mom, my calf hurts or my hip hurts, and I don't know if I can run anymore. I'm like, yes, you either talk him off the ledge or let him know it's okay, that you can still train. Here's biking and running. So the Pleasant Prairie race is unique, is that it attracts a lot of para athletes. And if you can see in these pictures, here's an athlete biking with a prosthetic leg. Here's an athlete not biking with his prosthetic leg. I saw people being carried into the water because they couldn't walk, but they could still swim. Here's somebody who is blind, and so this person had he had a buddy to help him through. And what I noticed as I was watching all these athletes come across going through the race, because you could see the race in various points, that the para-athletes, you couldn't tell the difference between the para-athlete and athlete. Everybody was determined to do their best. Everybody was having fun. And it can't help but think about how these para-athletes, like my patients, when I see them when they're in acute injury or pain, they were probably the same, where in the beginning phases of their rehab, they're more worried about how to function and how to deal with life and how to get from one place to the next, how to get dressed, how to walk, how to go to the bathroom. And doing a triathlon probably was the furthest from their mind. And maybe they went through a gamut of emotions, anger, sadness, denial. But what struck me watching these para athletes is they were past all that. They'd accepted their disability. They didn't allow their disability or limitations to define them. And they made bigger goals. And look at them, they're racing a triathlon. And so I remind my patients that today you might be uncomfortable and you can't do something, but you don't know what it's going to be like down the road. And we revise those goals as we go along. And I love nothing more than seeing my patients accomplish something big that they want to do. Now, maybe your goal isn't to do a triathlon. Maybe, I know we're talking about shoulder pain, but maybe you just want to walk without pain or get back to the activities you like to do without pain. Or maybe you just want to, you need to be able to do basic activities around the house like cooking and cleaning without pain. So today we're going to talk about shoulder pain, and we're going to discuss the 3 most common diagnoses, give you a little bit of an anatomy, physiology lesson, biomechanical lesson, and some things you can do about it. Now, I put this slide here because this is not an official diagnosis. A diagnosis is a medical diagnosis. You have a tendinitis, you have an impingement. But what we see that everybody has, and then some people don't really have those things, but they have this. They have postural weakness or a movement disorder. Things aren't moving the way they're supposed to. And we're going to talk about that some more in a bit. So people with shoulder pain, they all have similar complaints, and kind of based on the complaints, we can kind of discern what's going on partly, right? People have trouble sleeping because they can't lay on the shoulder. They can't lift anything over their head. They may have trouble washing their hair or getting dressed or putting on deodorant under their arm, opening and closing doors, putting your hand in your back pocket and toileting. Women have trouble doing their bra. And then they can't do their favorite activity. I can't play tennis or pickle or golf. The 3 most common diagnoses, there's certainly others, but this is what we see here in our clinic. And this is what most people, when they have a shoulder problem, will have. They'll have some sort of tendinitis, or an impingement of the rotator cuff or bicep tendon. You might have a frozen shoulder, officially known as adhesive capsulitis, or you have some degeneration, arthritis. So we'll talk more about those diagnoses in a moment, but let's do a little anatomy lesson here. Under all that soft tissue and fat and muscle and tendons is your skeleton. And I put this here to remind you that every bone is connected. So that song, the foot bone connected to the knee bone to the shin bone, is true. It's all connected. If you have a problem up here, it could be a problem. You have pain up here, in the shoulder, but it could be because this ankle and foot isn't doing what it's supposed to do, because if this isn't doing what it's supposed to do, this can't do it, this can't do it, and this can't do it. Very important to remember that. That's where that movement disorder comes into play. And you can see, if you took away all that soft tissue and you're dancing around, your skeleton's moving all over the place, like a bunch of shock absorbers all throughout your body. And if something's not, if you're having pain somewhere, we got to look throughout the whole body to see what might be causing it. All right. So let's talk specifically shoulder. this is the skeleton of the shoulder from the back view. We call it the posterior view. This is your scapula. Some people call it your backbone, your wing bone. And that scapula is connected to your arm bone, known as your humerus. And it's also connected to your collarbone, your clavicle. Okay. Around the scapula, it sits on your thoracic cage, your rib cage here. And so this is actually a joint. We call it the scapulothoracic joint. So when that arm moves, the scapula moves with it in a certain rhythm. You can see how that moves right there. Okay, so it needs to be able to freely move across your rib cage. And if there's some adhesions or some tightness or restrictions there, it will cause stress and strain up in here. This ball and socket joint is really what we all think of as your shoulder. It is a ball and socket. It's officially called the glenohumeral joint. This is where if there's a problem of the muscles and tendons around here or ligaments or capsule, this bone can glide and move in this joint and smash into those soft tissues, causing an impingement. We talked about the special rhythm. All right, so this is now a front view of your shoulder without the rib cage. So this is the inside of the scapula sitting on your rib cage. Here's your glenohumeral joint, your humerus, and this is the cartilage and capsule in between. Here's your collarbone, clavicle, and the AC joint. The AC joint is named for this component of the scapula called your acromion. We don't see a whole lot of problems there unless someone fell pretty hard, particularly like off a bicycle or something. Then you might have some AC joint issue. So most people have heard of what the rotator cuff. What is it? It is four muscles that sits like a cuff over this ball. You can see it here. It's four muscles. Two of them are back here. One of them up here. And then one of them sits on the inside here. And so what that does, when it's working the way it's supposed to, it holds the ball in the socket here of the scapula. So when you move your arm and it rotates up like that, it stays in the socket. If there's a tear or a tear in that rotator cuff, that ball might glide out of the socket, and then you impinge the muscle or the tendon here. The tendon attaches the muscle to the bone, and you get what's called an impingement where it bangs into two bones. Now, some people, that's if you have a tear. Some people get impingement because this rhythm, because the muscles surrounding this joint are not doing its job to move this joint in the rhythm that it needs to. So the big portion of our therapy is retraining how to stabilize the scapular muscles here, so then it moves in the correct rhythm with the humerus, so the rotator cuff can do its job. So I had a patient, Debbie, who has been an avid tennis player her whole life. She's maybe 60, I think she just turned 65. And she came to me with some rotator cuff and bicep tendinitis after falling, and she couldn't play tennis anymore. So we worked on really retraining her scapula to work, and so she could stabilize her arm when she goes to hit the ball. I guess this is really just another picture of the rotator cuff here. Okay, so you can see a little bit more on the back side here, the underside one, and then up at the top. This is on the inside. This is that subscapularis that sits between your scapula and your rib cage. And that's when, things get really tight in your armpit when you go to raise your arm up. So what often happens is people have pain. They don't use their arm efficiently anymore or optimally. They may not be able to raise their arm as high as they normally could. And then all the tissues down here get tight and restricted. And we got to get in there and loosen that up. This is the bicep tendon. biceps, meaning two. That means there's two heads. This is the long head and this is the short head. And it comes down and it attaches to your forearm because it bends, moves your elbow. This tendon here can often get impinged up here. So we have to discern, is it the bicep or is it rotator cuff? More often than not, it goes hand in hand. What I find, if it's really just bicep, the couple complaints I get are it's hard, it's painful to pull a blanket up. It's painful to pull my pants up. It's painful to get into my back pocket. Okay, but it might not be so bad moving the arm. Rotator cuff, it's hard to raise your arm over your head. It's very weak. It's much weaker than if it's just the bicep. What else? Okay. So I had a woman, Jennifer, who had bicep tendinitis. She initially came to me after she had had a round of PT elsewhere for some rotator, for some frozen shoulder, which I'm going to talk about a little bit, but I'll talk about it now. A frozen shoulder is when you develop adhesions in the joint, that ball and socket joint, and it's literally like glue stuck in there. From what I understand, we still don't know why. I know there's a lot of talk online about perimenopause and menopause. I am not up to date on the latest literature. However, we do know, and I've known for years, that it happens more often in women. It happens more often over the age of 40, 45, up to age 60 or so. I have seen men with frozen shoulders too, so we don't really know. What this people with the frozen shoulder really have trouble reaching behind their back. They can't reach overhead. They can't do their bra. And it doesn't hurt except at the end point. Okay. And it's important for us to know if it's a frozen shoulder, to differentiate between a frozen shoulder or arthritis, because a frozen shoulder, we're going to be more aggressive to get that mobility back. If it's arthritis, we don't want to be aggressive. We just want to keep you mobile. So I had a woman, Jennifer, and she had seen a round of PT for the frozen shoulder. And then once that kind of thawed out, I think she had some rotator cuff tendonitis. At any rate, she was pretty good, but not 100% when they let her go. And she came to me and I said, "Oh, what's your bicep?" And she's like, "Oh, nobody said anything." And so we did the work that you need to do to get your bicep working again, with the scapulohumeral rhythm. And she was much better. So here's a nice way of, so if you put your first and last name and your email in the chat box, I'll be able to send you this PowerPoint and you'll have access to this nice little chart and the whole PowerPoint so you can differentiate what's causing what. So rotator cuff tendinitis or the impingement. Usually we can find a pretty specific point that hurts, usually on the rotator cuff somewhere, usually in the back. It hurts to lay on your side. It's nearly impossible to do overhead movements, and there's a lot of weakness. Bicep tendinitis, I talked about, pulling up the blanket, pulling up your pants, and there's a specific point tenderness right on the bicep, and leaning on your hand can be a problem. I just gave you the talk about the frozen shoulder, and then arthritis is really pain with movement and weakness, and we really need to see an x-ray to discern if this is what's going on or if it's something like this. And this is why when people are older, we really want you to see the doctor, get an x-ray, because if it's arthritis, we can't push you too hard. Mostly we just want to make sure that you stay mobile and you don't lose any mobility. You can't really push it too hard to get stronger either, because you could flare up the arthritis. So we really want to know what's going on there. These other things, an x-ray doesn't tell us a whole lot. An MRI will tell us if you have a tear, but we can still treat all this without that MRI. The MRI usually shows up if PT is just not progressing after 6 to 8+ weeks. Then we might do an MRI to see how bad the tear is. A little bit more information about a frozen shoulder, also known as adhesive capsulitis. You do go through a few stages, and usually people start having a lot of pain before they lose mobility, and it can be very painful. And then at some point, it just kind of plateaus and you can't move anymore. Uh, you can only move to a certain point, and that's when you start coming in for therapy around here when things are starting to thaw, and we start kind of cranking on it, unfortunately causing some pain to move through this and break up those adhesions. And it can take anywhere from 2 to 12 months or more. Typically, the treatment for frozen shoulder is physical therapy. I have met a couple of people in my career that were not successful with physical therapy, and they were in just so much pain. The doctor then did a manipulation, and I'm not sure if they did anything else because I didn't see these people again, to open up that joint so they can move again. We talked about arthritis. All right, so now we're going to get into, actually, let's do this first here. So postural weakness, movement disorder, and mobility. So I had a woman, Kathy. She came to me and she had some chronic neck and upper back and shoulder pain. And she was doing a lot of forceful massaging in that area, and it would provide very temporary relief and sometimes would flare up even more. And she was very weak in her core. And when your core is weak, everything above it doesn't have any support. So everything here has to work harder. And so you don't use your arm as effectively when your core isn't working. As well as I had Jamie, he was, his rib cage was really tight, his thoracic. So when he used his arms, he didn't move to use the rib cage and core effectively. So then he just kept overusing his shoulder joint, causing pain. I get a lot of people where I have to teach them how to move through, actually everybody, to teach them how to use their body and their core so they're not overusing that joint and stressing and straining it. So sometimes if we catch it early enough and people have come in with pain, it's only this. They're just not moving well. I see this like with dentists, because they're sitting and they're very immobile and they're just moving their arms. So you get this overuse syndrome. And so we got to work on teaching them how to use their body so they don't overuse that joint. A lot of the problem comes into play because of poor neuromuscular control, using their core and their shoulder effectively together. So I'm sure you've heard of your core. It's every muscle from below your diaphragm to your pelvic floor, in the front and in the back. And everybody has this six-pack muscle, but not everybody, you can't see it on everybody because people's fat layers and whatever, just they don't show definition like everybody. The deepest abdominal muscle is called your transverse abdominis, and that's like a sheet of armor that goes all the way around. And I teach my patients a little trick to engage. Let's back up. Transverse abdominis should always be engaged, and it should be a very subconscious thing. But more often than not, for whatever reason, it's turned off. People are not using it effectively, and it's an unconscious thing. It's no one's fault. Something just got askew. So to learn what it's supposed to feel like, this is a little trick. You put your tongue behind your top teeth and make a TH or an S sound. In order to make that sound, that transverse abdominis has to engage. So if you give me your first, last name, and your email, I will send you some videos of this. The video is also available on my website and the YouTube channel. So when you have a weak core, and as we age, our spines change, and so our posture changes. I personally have a little pet peeve when people come in and tell me, oh, my spouse says I have terrible posture. Or patients tell me I have terrible posture. or I was told to always throw my shoulders back. I don't believe anybody has terrible posture purposely. People's bodies change with time, and everybody is just trying to adapt. And you figure out the best way you can. So you can see if your spine starts flattening out like this and you get tight in here and you're bent forward, in order to see, you have to kind of lift your head up. And so it causes all sorts of different problems, okay? This is kind of a common rounded thoracic spine here of osteoporosis. Here's a scoliosis. You can't control what your spine does. It does change over time. What we can do is work with all the muscles and tissues around it to keep it stable and as mobile as possible, and to help you forgive yourself, to not shame yourself for having bad posture. Back to, we talked about my patient Kathy with a weak core. If you have one weakness or something that's out of whack down here, this whole thing comes tumbling down. So I can have someone come in with neck pain, jaw pain, and I need to do something on their feet. Remember, everything is connected. This is another little tip I like to give people, and this is, you remember that postural picture I just showed you, and there's some here. More and more people, as their spine changes, in order to see, they tend to bend backwards right here, coupled with, I'm trying to stand up straight. So they're throwing their shoulders back, okay? And then they're extending their spine. So two things with that. Number one, you're extending your spine here, which shortens the muscles here, causing them to work all the time, and you will have back pain. Throwing your shoulder blades back, remember your shoulder, the arm bone, your humerus, and your scapula is connected. If you throw that shoulder back, and then your arm bone is back there as well. So when you go to try to use your arm, there isn't enough room to move it. So this is a real problem. So I am forever telling people to lower their chest so they don't extend here. And I often, this is a little exaggerated, but have them kind of bring their shoulders forward as well. So that scapula comes forward. So that joint is sitting in a much better place. If you can do these couple of changes, and then when you go to move, always think about using your body when you move it. I may have some more pictures later, I'm not sure, but so like if you guys are taking exercise class at the gym there, or at the Y, and you're moving your arm, make sure you're not just doing your arm, make sure you get your body moving with it. And so if you're going to reach for a dish overhead, make sure you turn and use your body, okay? All right, the thing that everybody hates, aging. It is better than the alternative. So everybody ages, everybody's body changes. We all lose muscle mass, we all lose bone integrity. And because of that, our balance becomes worse, our flexibility becomes worse, we become weaker. And we have to work at it to maintain that and to keep us safe. But it doesn't stop you or limit you from doing anything. This is my friend Carney. He's 73 years old and he's still doing triathlons. These ladies, I love this story. So this is from 10 years ago. I was at the Gasparilla. I was doing the half marathon. And this was the day before the race. I was standing in line at Starbucks. It was a really long line because we had a really long conversation. And I noticed these three women had medals around their neck. I'm like, why do you already have medals? And they said, well, we just walked the 5K. I'm like, oh, wow. She goes, yeah, we're doing the triple challenge. We're going to do the 10K later today, and then we're doing the half marathon tomorrow. At the time, this woman was 70. I think this was her 80th birthday. See the happiest birthday? And she was somewhere in between 75. They did not let age limit them. You know what else they did? We kept in touch. These women had a goal to walk across America, and they did. They put their foot into the ocean in Jacksonville, Florida. And then it was these three plus, I think, three other women. They walked all the way to the middle of Texas. They had a van. They all took turns. There was a whole system to what they did, but they did it and they got to middle Texas. Maybe it took 4 months. I don't remember. They took a break and they came back to middle of Texas and they walked all the way to San Diego and put their toe in the Pacific. So I love to use their story as encouragement. Again, this may not be your goal, but the lesson here is they didn't let their age limit them. But we need to understand what your limitations are, and I'm going to help you. We help you accept them and understand them and know what you can and can't do. All right, so now let's get to what can we do about it. I talked to you about how the diagnosis is important. Oftentimes, sometimes people come to us before they see the doctor. Based on our exam and what you tell us, we can come up with a working diagnosis, and that should be sufficient. Sometimes we want you to have an x-ray to make sure it's not really severely arthritic. It's rare to get an MRI right away. How do we know if physical therapy is going to help? Well, is your pain reproducible? My arm only hurts when I raise it overhead. My arm hurts when I lay on it. Otherwise, it's okay. Then we know we can do something. If you have pain all the time and it's just always achy and it's not going away no matter what you do, we need to look into maybe other things. You definitely need to go see your doctor. I myself woke up one morning with some back pain and I never have it. And then after a couple of days, it traveled around to the front of my stomach. And then it was just constant and I couldn't sleep or get a position to sleep in. And I went to the emergency room. We didn't figure it out. And a week later, I had a rash on my lower back. I had had shingles, but I had pain before the rash showed up. So that's not really something that physical therapy deals with. But, some of those symptoms, once you're treated medically, can be helped with some of the non-traditional stuff we do, plus acupuncture. So what is the biggest mistake people make with shoulder pain? They ignore it. So you have a few choices. You can ignore it, can alter it with medications, injections, and surgery. There is a place for this. I'm not against it, but we want you to learn how to use your arm efficiently and effectively so you don't keep injuring it, so you don't keep aggravating it. And maybe you can avoid this. So here at the Manual Touch Physical Therapy, when you come in for an evaluation, we sit and we listen to your story. We want to know your whole history or your medical history, any surgeries you've had, any accidents that you might have had. We want to know what causes your pain, what helps your pain, what makes it worse. And that's the beginning part of putting the pieces of your puzzle together. And then we evaluate you. We check out your mobility, your strength. We poke around a little bit. We look at your gait. And even if you're coming in for shoulder pain, we're going to look at everything. Because you never know, why. We need to see what may be limited somewhere else that could be causing your shoulder pain. So I had a woman come in, Lynn, she's 78 years old, and she'd had neck pain for many, many months. And she'd gone to a chiropractor and a massage therapist for 4 months. She had no change or no help. This is a little bit of a soapbox, but if you're seeing a practitioner for 4 months and you're not getting any relief, that practitioner is being unethical by not sending you on to somewhere else. If you're not getting some change within 4 to 6 weeks, we need to look at something else. Doesn't mean you're ever going to get better in 4 to 6 weeks, but there should be something. She had an MRI of her neck. It was insignificant, typical 78-year-old neck. She came in to see me. I did something a little different to settle down her neck pain. And then I looked at her shoulder more closely. She had a rotator cuff tear. and she was overusing this upper trap muscle that covers your neck. So she was having neck pain, and it looked like neck pain or neck problem, but it wasn't coming from her spine. She was overusing her neck muscles because her shoulder was so weak and problematic. So it's really important for us to look at everything. All right, so when you come in, what are we going to do? We're going to do some hands-on work, manual therapy. There's some traditional treatments where we do some joint mobilization to make sure all your joints are balanced out. We might do either traditional or non-traditional hands-on technique. One is a little more aggressive than the other. We give you some exercises to get stronger, to make sure your mobility is better and your balance. Most importantly, we give you exercises for neuromuscular reeducation to get your body working together. And then a key component of my job is to educate you on how to move your body as efficiently and optimally as possible. We're going to teach you how to sit and how to stand and how to walk. I'm sure you think you know how to do that now, but with all the bodily changes that you go through your lifetime, people just make do. They take the path of least resistance subconsciously, and over time, things are not working as optimally as we need to. So we're going to teach you how to do everything that you just naturally have done your whole life. And then if you have a specific goal in mind, you want to get back to tennis, we're going to work on some tennis things, movements, golf, pickleball. Maybe it's just doing some cleaning in your house that we need to get back to. How to sleep. One of the tools we use here is called an OOV. I learned about this about 6 years ago. I don't know what I did before I discovered this. It's a device created by an Australian osteopath. It works your body three-dimensionally, so you cannot compensate. It subconsciously activates your core no matter what position you are on. You can be on your back. You can be behind your back. You can be standing on it. You can be on your stomach. You can be on your side. You can be older. You can be a younger, like my son, and doing a very advanced technique. It is an amazing tool to help re-educate your body to work together. The second piece of equipment he created is called a balance sit. And it's just for that. It's designed to sit on. But again, subconsciously activates your pelvic floor and your core. It is not designed to sit on all day. It is an exercise tool, 10, 15 minutes at a time. Here's a friend of mine sitting on her balance sit and doing an exercise. So remember my son at that triathlon? He got 8th in his age group. He was happy with that. It was his first race after a few years. He trusted his healing process. He was excited to be there and just had fun. This year, so that was maybe 3 years ago. This year, he did the Chicago Triathlon and he seems to be back on track. He got second in his age group. And I think he lost by like 0.1 second or something. So he's a pretty good triathlete. As a thank you for coming in today, I'm happy to talk to you on the phone to do a 25-minute consult. Just give us a call and my admin will schedule you. This is a tip sheet you can find on my website, or I can send this to you if you give me your email on tips on how to take care of A, prevent shoulder pain, and B, what you can do about it now. With some resources, ebook that I will send you as well, and my contact info. All right, so I'm going to stop this and we're going to see each other again. And if you have any questions, I'd be happy to answer any.
Thank you so much, Denise. While we wait for anyone else to come up with questions, I did have a couple, just kind of wanted to get the ball rolling. The first one is very logistical. Do you take Medicare or insurance?
I do. I am a Medicare and a Blue Cross provider, and we do bill every other insurance without a problem. If you are on Medicare, you do need a prescription from your doctor. If you are on private insurance, you do not need a prescription.
Got it. And then what are your other like focus areas or specialties that you cover in your practice?
We see a lot of people with chronic pain, chronic uh, issues, but any pain anywhere, your shoulder, and I do talks later on in the year. We talk about your hip, your back. Probably the majority of people I see have back and neck pain. I had a woman just recently after had some major foot reconstruction. I'm seeing a lot of people with hypermobility syndrome, and that's a spectrum of disorders. Usually we find it in young women, and as people get older, they have other issues because of it. I see what else? Vestibular, people with vertigo,
Mm.
headaches a little bit, particularly if it's coming from their neck. We can discern. We certainly can work on that area and see if it helps. So anybody with pain, mostly with pain and loss of function, if you're not moving well, people get stiff as you get older and things just don't move as well. And and balance goes down, and it's really important. I tell my older folks probably once they hit age 65 or 70, I like them to come back every year for a tune-up and to check in because unfortunately, as we all know, it's kind of downhill as we get older. We lose muscle mass, we lose strength, and our chances of falling increase.
Mm. Thank you.
Okay. All right. So thank you for having me today. It was wonderful. And email me, call if you have any other further questions. And I think I might be I don't know if I'm doing a talk next month. Yeah, I'm doing one in April.
Yes.
I don't remember
Yes.
what it's on. I think it's on the hip
Mhm,
pain.
mhm, mhm.
I
Yeah.
get a lot of women with hip pain because women's hips are weak, particularly as they get older, and we need to have strong hips to protect our back and prevent us from falling.
Mm. Great. Great. The recording of this will go live either Friday or first thing Monday. And then any sort of contact information or follow-up links from that was in Denise's presentation, I will make sure to send out to everyone, including that link to the quiz, the test that you had mentioned, where it's like you click on it and then you just kind of see what's going on with your body. It was halfway through your presentation.
No, I didn't have a test. It was more of there's in the PowerPoint, there was, a nice chart so you could kind of,
Oh, yes.
I think that's
Mhm.
what you're referring to.
Yes,
That's
sir.
okay.
But yeah, but that will be, I'll send it out as a follow-up email with the link to the video as well. Mhm.
Okay, cool.
Right.
Well, thank you for having me, everyone. Have a great day, and maybe spring is on its way. We're in the tail end of winter. Take care. Thank you. Bye-bye.
Bye.